Today on Diagnosing Healthcare, we're discussing 42 CFR Part 2 final rule changes. We'll be reviewing the most significant changes and what has stayed the same under Part 2, how the changes under the final rule align with HIPAA from a compliance and enforcement perspective, and we'll also be reviewing operational challenges and hurdles associated with complying with the final rule. Hello and welcome. I'm your host, Laura DePonio. I'm an attorney in Epstein Becker Green's healthcare and life sciences practice, and I'm based out of our Boston office. So 42 CFR Part 2's final rule compliance deadline is rapidly approaching. By February 16th, 2026, Part 2 programs, their business associates, and qualified service organizations, and other participants in the healthcare ecosystem, such as clinicians, primary care doctors, payers, and HIEs, must be compliant with the provisions. Significantly, this new rule has upped the enforcement ante by adopting HIPAA's enforcement and penalty structure for Part 2 violations. Therefore, Part 2, despite its long history of non enforcement, can certainly no longer be simply ignored. So, during this podcast, we will be reviewing some of the most fundamental changes to Part 2, as well as what has not changed. We'll be identifying how Part 2 will better align with HIPAA and what additional obligations that might pose. And we'll be discussing what we see as ongoing operational challenges that every entity in this space will have to navigate going forward. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. I'd like to introduce our guests today. Joining our discussion, first up is Lisa Pierce Reisz, a member of the firm at EBG in our Columbus, Ohio office.
Thank you, Laura. It's great to be here today. Super excited to talk about this topic, which does have a very imminent deadline now.
Yeah, it came up quickly. Next up, we have Nichole Sweeney, General Counsel and Chief Privacy Officer from CRISP Shared Services. Hi, Nichole.
Hi, thanks so much for having me. It's always fun to talk about this topic, and I'm excited to be joining you all today and talking about how my company has helped operationalize this for health information exchanges across the country. So, have some experience, have some, sort of don't do this, do this, and it's fun to be able to talk about that while folks are still trying to figure out how to comply.
Thank you so much for being here. And finally, we have David Shillcutt, who is also a member at EBG. Hi, David.
Hi, thanks. Yeah, I had the interesting opportunity to work on these rules in prior roles at CMS and SAMHSA, but I'm super excited to hear perspectives from Nichole and Lisa about how they've been working with folks to implement, and really interested to hear thoughts on what these new rules are going to look like going forward.
So 42 CFR Part 2 is 50 years old. Lisa, can you provide some general background and context about the changes that we're talking about today? Have so many stakeholders pushed to get this final rule across the finish line?
Yeah, Laura, it's a really interesting story on Part 2 and how we got here today. This is not a new rule by any stretch. It was enacted originally in 1975, and the updates from last year were part of the requirements of the 21st Century Cures Act from 2020. These changes are meant to better align Part 2 with HIPAA, with the primary goal of improving care coordination for patients with substance use disorders, and we'll refer to them all day today as SUDs. But they've been born out of and continue to reflect the historical tension between Part 2 and HIPAA's historical approach to patient data sharing. So, as I say, Part 2 was enacted in 1975, and it always prioritized absolute confidentiality in order to encourage SUD patients to seek treatment without fear of prosecution or stigma. And there's this whole public policy view that if folks don't seek treatment, the entire sort of societal SUD challenges will either persist or worsen. HIPAA, which is not new, but much newer than Part 2, enacted in 1996, was designed to facilitate broader information sharing for care coordination. So, for decades, this sort of tension has created this legal and operational gap that's hindered basically integrated care. And so, you have these two camps where you're trying to get better data sharing to improve patient care, patient quality, patient care coordination. And yet you've got sort of this other camp that says, wait a second, we can't share. There's going to, we're going to disincentivize people to get treatment. So again, for many stakeholders, there's a hope that these new rules are going to kind of thread that needle and really do improve care and quality outcomes for patients. But there still is a number of folks in this SUD treatment community that remain concerned that even with these new changes, the broader consensus, patients may not likely anticipate the extent or the consequences of a disclosure right up front that could continue to disclose and redisclose, which wouldn't have under the old rules. And once disclosed, it's hard to undisclose. So you still have that tension, and that's sort of the background context of how we got here.
Yeah, really helpful. And I think, probably one question that all of us have gotten at one point or another multiple times. David, what is a Part 2 program for purposes of determining who the final rule applies to?
Right. Yeah. So that's a really key point that sometimes is overlooked, is that it's not a Part 2 record unless it was created by a Part 2 program. In brief, it's most providers of substance use disorder treatment. More specifically, you've got to be federally assisted, most, unless you're self-pay only, then most providers, one way or another, are going to be getting some form of federal assistance these days, participation in Medicare, Medicaid, grant programs, et cetera. Really, the key point is, are you holding yourself out as providing substance use disorder diagnosis, treatment, or referral? That's a really interesting question from the perspective that it has never really been enforced before. It is somewhat of a gray line. And it's something that I think a lot of primary care providers and other providers who think of themselves as medical surgical providers, but that are providing some volume of substance use disorder treatment, need to make sure that they are thinking about and that they're documenting in terms of whether they are going to determine themselves to be holding themselves out to provide substance use disorder treatment, and just make really sure that they are clear on where they fall on that line, given the really important downstream consequences.
Yeah, Nichole, following David's comments, what other stakeholders need to be aware of and compliant with the final rule?
Sure. And I might actually bucket that into two questions or two different versions of that question. The first one is, I think it's just important to talk about Part 2 on a regular basis, because it's always interesting to me how many providers and payers and folks that are just generally in the healthcare system aren't aware of Part 2 to begin with. Or you'll say Part 2 and they'll be like, "Oh yeah, I've heard of that," but don't understand its consequences. And so if you don't have to comply with it, right, it's easy to sort of just say like, Part 2, yeah, okay, that's not my thing. Lawyers for somebody else have to deal with that. But if you're providing care to patients, if you're providing care coordination, if you are paying for care, it's really important to understand where your gaps in your information are. And there are really devastating consequences to patients if you don't understand sort of fully their history and their records. So, this isn't necessarily what this podcast is about today, but whenever I talk about Part 2, I always try to put a little plug in for providers, especially those providing care in a primary care setting or an emergency setting, to just sort of have a tickler in their brain that you're missing quite a bit of data potentially in this area. And so it's probably a good idea. There's sort of, lists of things that doctors, clinicians normally go through, like, do you have any allergies, right? You expect that to be in the record, but they're just taught as a matter of course. Always ask that, right? You want to make sure that you're not missing an allergy to a medication. So always ask that question, even if you think it's in the record. Similarly, I always encourage folks just to ask their patients, hey, are you receiving care somewhere else, that I need to be aware of? That you might not be, but let me just like briefly talk to you about substance use disorder. And if you're receiving care in one of those places, I might not have those records, and that could affect your care. So that's not necessarily what we're talking about today, but I do think that's an important plug for providers, because it's data that you're missing that could really have devastating impacts on patients' care. It can even be life-threatening based on what you prescribe to them if you don't have all of that information. So back to our regularly scheduled programming. I think a couple of other, stakeholders that should be and aware of this. One, and obviously I'm speaking a little bit from a self-centered place as a technology provider, is technology providers. So if you're going to be exchanging data on behalf of providers or payers, it's important to understand how this rule could change and does change that exchange landscape, and making sure that your technology is compliant by February at the very latest. And to the extent that you need to talk with providers, talk with payers, talk with care coordinators to make sure that they understand sort of how their technology might be a little bit different things that they are going to see. I also just really want to put a plug in for payers. I keep talking about them a lot. Well, I think we'll get into that quite a bit in this podcast. But the folks that I've seen that are the most interested in these rule changes are specifically Medicaid, MCOs, and other Medicaid agencies, because as we'll talk about, for the first time, there can be one consent that allows not only treating providers, but also payers to see these data. And that is really just hugely transformative for how you treat patients, specifically as MCOs. So always like to put that plug out there too. If you're a Medicaid agency, if you're a Medicaid MCO, this is definitely something you want to be paying attention to, and how it might impact your overall patient care.
Yeah, thanks for that. I mean, I think the context is important, and great that you went rogue, because so often I think the desire is sort of to take a very, black and white approach to what privacy regimes kind of apply to your business. And there oftentimes is a compliance and strategy component where they really intersect, or important to consider them both. So Nicole, to sort of dig in on the changes that we're talking about today about part two, you we've talked about, it's critical to understand what is not changed. And can you talk about a bit about the patient consent aspect in all of this?
Sure, absolutely. So as I've hinted at and talked about, at Chris Shared Services, we have implemented this new rule. So the rule was published, and then you had a 2-year compliance period that was sort of a choose your own adventure. Like you could decide to implement it if you wanted to. And we did decide to at least have the technology available to implement it. And many of the HIEs that we support did decide to do that. So because of that, I say that one to toot my own horn, of course, because I'm very excited that we did that. But for purposes of this podcast, I say that because I have sort of firsthand experience with a couple different stakeholder groups in a couple different states, where we started talking about this rule and how we were going to be updating our technology and also updating things from an operational perspective. That what I kept hearing was, well, this is great. As a technology provider, aren't you just deleting all of the rules? Because part two is like HIPAA now. That's the like phrase that I heard over and over and over again. It's just HIPAA. It's just HIPAA. To the point that even though I'm a quote unquote expert in this area, and like read the rule backwards and forwards and commented on it, and then read the final rule, I was like, did I miss something? Um, like I heard it from so many different people. And so there is this, I think, sort of, it's easy sometimes, right, to do the soundbite of like, oh, it's aligned with HIPAA. And what folks have been hearing, I think, from experience, I know from experience, is it's just HIPAA. And so the outcome of that is the folks that we've worked with have said, okay, this is great. We don't even need to collect all of these consents anymore. Just, align your technology rules, align your operations, align your patient conversations with anything that you would say in HIPAA. And that's a little bit true, right? Like that's the soundbite and the nuance, right? The difference between being aligned with something and being something. So where the alignment really comes in is that the purposes that you can exchange data for, whether you're doing that via paper or electronics, is very similar to HIPAA. It's that treatment, payment, and operations. And you can do that with just one consent now. And in prior days, you would have to get You could get one consent for treatment to say, yep, we're going to share this with all of your treating providers. But for payment, care coordination, operations, that includes care coordination or public health analytics, or excuse me, population health analytics. Public health is another category altogether. You would need separate consents for all of those entities. So now you just need one consent. But the big thing there that I've said probably, I don't know, 27 times already is consent, right? In a normal HIPAA type atmosphere, the patient consents to their data being shared simply by being treated. You don't need an additional piece of paperwork, but you still need that paper here. And importantly, all of the rules that go after that consent, or at least most of them, still apply. So you still have to know it's Part 2 data. It doesn't magically unbecome Part 2 data. You still have to, from a technology perspective, tag it, know where it's going. There are other disclosures that would be allowed under HIPAA besides TPO that require additional levels of consent in Part 2. So you have to keep those in mind. And you have to allow patients to revoke consent. So not only do you have to be able to tag this and know where it is, but you have to be able to bring it back into under a consent wall if a patient decides to quote unquote unconsent. So you have to keep that in mind. There are a lot of things that make this easier, but to Lisa's point at the beginning, we still want to make sure that we're incentivizing care. And so there's sort of this tightrope that these regulations walk between being as aligned with HIPAA as possible and allowing that greater patient choice.
Yeah, so to pull that thread a little bit farther on the HIPAA piece, Lisa, we know that there have been a number of changes to Part 2 under the final rule to better align it with HIPAA, some that Nichole just talked about. Why and what are those changes? Can you expand on that a little bit more?
Sure. I think Nicola set the stage perfectly because I'm having similar conversations that this isn't just about moving to HIPAA. And that's an incredibly important point. There are some things I feel like Part 2 has been in sort of this void for a long time, where frankly, a lot of Part 2 providers are HIPAA covered entities. And yet they've got this tension between, wait a second, is it Part 2? Is it HIPAA? What applies here? And so I think that this final rule at least specified much more clearly HIPAA obligations that folks might have been ignoring. But again, as anybody in this space knows, HIPAA is the floor. And so Part 2 typically being a stricter rule, if something conflicts, Part 2 is going to still apply. And so to Nicole's point, there are still a number of Part 2 things that we have to comply with as you use and disclose Part 2 SUD records. So they're working better together. And I look at these rules as, yes, it's an alignment, it's not a replacement. And so I think it answers some of the questions that maybe we're missing. Or one of the other benefits, hopefully in theory, and we'll see how it actually works in practice, is are these final rule alignment going to lower some of the administrative burden on Part 2 programs as they were trying to frankly comply with two different schemes? So, there's probably a checklist of at least some of the important things about alignment. One of the big ones that is going to be due in February is going to be every Part 2 program now has to have a HIPAA notice of privacy practices. In practice, that may look somewhat like your old privacy statement, but again, there is under 164.520, there are very specific requirements now for a HIPAA notice of privacy practice that you have to then insert and weave in the Part 2 language that both rules will hopefully play together. For non-Part 2 programs, if you have Part 2 records or going to touch Part 2 records, you're going to have an update to your NPP as well to again deal with your obligations as holding now Part 2 records as a corresponding treatment provider, a payor. So every covered entity should be looking at their NPPs if they in any way touch a Part 2 record. So that's the big one. Part 2 has now adopted some of HIPAA's patients' rights, like the right to an accounting of disclosures. Under HIPAA, it's 6 years. Under Part 2, it's going to be 3 years. We're still waiting for the final rule under HIPAA for both of those to be finalized, but it's a concept now that Part 2 programs need to be aware that there is a right there. There's a right to request restrictions. Like HIPAA, a Part 2 provider doesn't have to agree to the restriction, but unlike HIPAA, if you don't agree to it, you can't produce it, you can't disclose it. So there's, again, some nuances to Part 2. Part 2 does not go away. There is the adoption of a HIPAA's breach notification standard, which is, I think, a really good thing, honestly. Every single entity in the country, healthcare and otherwise, is dealing with breach and dealing with their, risk to data. And I think there was always this tension in Part 2 programs. Well, does HIPAA apply? Are we under this scheme? If you have an unauthorized access or disclosure, you're going to the HIPAA rules and looking at their breach test to determine, do I have a reportable breach? Every patient, whether you're an SUD patient or a primary care patient, has that right to breach notice now. Another thing that, and probably one of the scariest things for Part 2 providers, again, this has been the abyss of enforcement. I've gone to conference after conference saying, is anybody enforcing Part 2 for the last 10 years? And every regulator will say, nope, we're not doing anything on this. Nope, we haven't had any enforcement. There's been, although despite it's all been a criminal type enforcement under old Part 2, we've seen no enforcement at all. So I think folks have probably in good faith tried to comply, but there hasn't been a real stick over their heads for actual compliance. Under the final rule, starting in February, OCR can come knocking on your door, just like under HIPAA, to look at breaches, to look at potential complaints, and they can enforce. They can do civil monetary penalties, just like they do under HIPAA. And if it's bad enough, they'll refer to DOJ and still do criminal enforcement. So it's now under HIPAA scheme. Interestingly enough, under the final rule, providers, if they de-identify under HIPAA standards, they can disclose data to public health organizations. Again, probably for that population health and other studies like that. Um, there's an amendment to the definition of a qualified service organization to include HIPAA business associates. So those are better aligned. They've always felt similar. Again, there's still some nuances between the two, but the category has gotten bigger. And then finally, I just want to mention there has been an addition of an SUD counseling note component in Part 2. This is going to look and feel very much like HIPAA's psychotherapy notes and the required additional consents for those. So those are kind of the alignments at this point, the biggies. And again, I just want to reiterate what Nichole said. This is an alignment, but not a replacement. Part 2 still survives.
Yeah, it's the classic yes, but lawyer response,
Correct.
right? Yeah. So David, what are some of the operational challenges that you see as entities try to come into compliance with the final rule? Can you help us understand sort of where the rubber hits the road from a practical standpoint?
Yeah, there's some standard things that I think should be fairly routine for a lot of most companies in terms of things like you got to update your patient consent forms. Make sure that you're thinking about what types of consent forms you're using. Is it just the treatment, payment, and healthcare operations? Do you have a different consent form for the counseling notes? Do you have a process in place to account for patients who have some sort of non-standard scope of consent, like that don't want to release for all treatment, payment, and healthcare operations purposes, those kinds of things. Second, updating your policies and procedures to make sure that your PMPs align with the new requirements, updating your notice of policy practices, updating your business associate agreements or your qualified service organization agreements, maybe combining those types of things. But the real challenge, I think that a lot of companies are still not prepared to face, whether you're a Part 2 provider or whether you're someone who's going to be receiving these Part 2 records, is we've got this new requirement for the patient consent form to flow with the Part 2 record. So if you're transmitting or receiving a Part 2 record, you need to know what is the scope of patient consent that goes with that. And so whether it's the actual consent form itself or some other way of informing that recipient of the Part 2 record, what are my rights? What can I do with these records? And what can I not do with these records? How are you going to make sure that that each record is going to be tagged one way or another with that scope of consent? So if you haven't had these conversations already with your EHR vendor, with your payers, if you are a payer, with the providers in your network, to implement this in your claims platform, all the different, and Nichole, I can't wait to hear you talk about how you're doing this within an HIE context. But that is, I think, the number one challenge that a lot of folks are not ready to grapple with. In particular, that sort of non-standard scope, where you got patients who are not willing to share for all treatment, payment, healthcare operations purposes down the line. Are there contractual strategies that you're gonna follow, maybe to work with, whether especially if you're a recipient of Part 2 records, to tell people in your network, you need to tell me when you're sending me a patient record that has some sort of non-standard scope? Do you have technological solutions in place? That is something. I mean, all these strategies are things I'm still seeing play out in real time. And I think it's really important also to be engaging with regulators to talk about the challenges in implementing those. Talk about if your vendors are not ready to help you and you're trying in good faith, but you're hitting technological problems. Because I think OCR is still really interested to hear from others who are trying to implement this. How is this working out? Because historically, this was not. It was theoretically a requirement, but not explicit in the rules and certainly never enforced. So I think the regulators still have a lot to learn about how this is going to play out in practice. In addition, it's not just the treatment, payment, healthcare operations, also the other types of consent. Do you have are you going to flag those where needed? The important thing really to remember is that, I think Nichole said this earlier, you still have to have the consent, and you have to know, even if you have the consent to share for all treatment, payment, healthcare operations, there's still differences. Like, we got the Venn diagram almost completely overlapped, but it's those differences at the margin that mean that you still always have to know that this is a Part 2 record. Because if there's a requirement to disclose for legal proceedings, for example, then you might, or if the patient decides to withdraw that consent, you have to still be able to go in your system and identify, this is a Part 2 record. I need to treat it differently in this context. In the final rules, they talked a lot about how, well, you don't have to segregate these data, but I don't think that the regulators fully grappled with the fact that, I mean, whether you're going to call it segregation or flagging or, something else, you still have to be able to treat those records differently. Nichole, I am really curious to hear sort of like where you are in your journey on that, what sort of solutions you're seeing in the market, and how you think this is going to play out.
Oh, I could do a whole other hour on this. So I think, one of the things I like to get across anytime that I talk about these types of things is that the technology isn't actually hard. I get really frustrated sometimes when I'm at, various conferences or having conversations with folks, and they're like, "Whoa, we can't do this because, like, how would we blah blah blah?" And it's like, come on, come on. The technology almost always isn't hard, especially if you have something configurable like this, like what is a Part 2 record versus what isn't a Part 2 record. What's really difficult in most cases, how do you operationalize this? How do you talk to providers? How do they do the patient education that they need? And then as a business, how and when do you decide whether, I think, David, you said this so well, you're going to solve for the 90%, or you're going to solve for the 10%, or you're going to solve for the 100%, right? And so and this is just one example, but what we rolled out last January, and it took, almost a full year of planning. But for our technology, the consents are entered into the technology so that we know like exactly what the consents look like. And we decided to start by solving the 90%, and now we're working on the other 10%. And what I mean by that, the 90% is that we have one consent for treatment, payment, and operations. And if folks have consented to that, we, tag it, as you said, so we always know when it's a Part 2 record. But we share it with, for those purposes, with payers, with care coordinators, with treating providers. And then what we tell folks is most patients, or at least what we've seen from the data, is that the vast majority of patients are either going to share for everything or they're going to share for almost nothing. And so we provide education for those patients who don't want to share for everything. Okay, this is how you do it then, right? Like, this is the 10%. We didn't not solve the technology problem because of the 10%. Instead, we said, let's solve the 90% and then provide education for those 10%. So because we have that one consent, it allows us to put sort of a persistent, it's not sort of, we put a persistent pop-up on the data. Like when you scroll over it, that says it's sort of like this exclamation point that, and when you scroll over it, it says, this is part 2 data. There's the standard language that has to go with that. And then, the consent that the patient provided is substantially similar to this, and it links back to a consent form. So that's how we decided to solve, again, the 90%. There's some really interesting technology problems. I started off this part of my talk by saying, like, the technology isn't hard, but there are a couple things that are hard, and that is that there are some cases where putting that persistent redisclosure notification is difficult. It's not difficult if you're in the same environment. It gets more and more difficult as you share down the road, and that's some things that the industry is trying to solve. And then I think the other operational challenge that I'll just highlight is if and when you switch consent forms, right? So if you do what we did, and we had a treatment consent form, and now we have a treatment payment and operations consent form, at some point you have to decide, okay, when are we switching over, and how do we make sure these data are tagged just for treatment and these data are tagged for treatment payment and operations? So we did about like a 6-month educational campaign, had a rollout. I think we're running out of time, but there's a lot that you have to think about and do there, not from necessarily like a legal compliance perspective, but just from okay, how are we going to operationalize this? What is it going to look like? How do we make sure providers, patients, payers know what they are doing? So that, again, in my mind, is usually the hardest part. It's the educational part. But we actually, in the past year, have had more consents than ever. So we decided to sort of stop the treatment consent and then ask people to get the consents again, and did a huge campaign. And we have almost double the consents on file after doing that. So, it did require that education and outreach, but we did it. And it kind of comes back to, from a business perspective, deciding as a business, this is new. It hasn't been enforced, as both Lisa and David have said. So we're not going to get it right. It's not going to be perfect. Right. And as a business, you have to decide, what is your risk tolerance and how close do you want to get, and just know going in, it's not going to be perfect. But the downside is not the legal risk, it's the risk to the patients. And just going back again to what we talked about at the beginning of this, there are huge consequences to patients, potentially life-threatening. And you have to take that, in my opinion, in consideration when you're weighing how you're going to implement this and whether you're going to implement this. I know that there are going to be folks that decide, we want to see where this goes a little bit. We're just going to continue treatment consent, while we see how this plays out and how it's enforced. But it's really important to think about, not only the legal compliance risks with that, but also the risks to patients, as you go through that exercise as a company.
Yeah, so many great points. And, I think a lot of times we hear sort of like the, compliance by design theory sort of thrown out there. And, what you've described, I think, is such a great example of where that actually comes into play from an operational perspective. So, as we sort of wrap up here, let's do a series of quick fire questions. What can people take away from this? So Lisa, starting with you, if listeners should only do one thing after hearing this podcast, what would you recommend that be, and why is it critical? And is that an impossible question I've just asked you?
Laura, it's a hard question, maybe an impossible question. It's easy to say, if you're in depending on who you are, if you're a SUD provider, sure, you should be looking at all of your documents, your NPPs, your forms, your consent forms, your multiple consent forms. But maybe more importantly, and it kind of gets to both Nichole and David's point, is depending on who you are in this ecosystem, how are you going to operationalize all of these new requirements to, again, make sure that you are disclosing when you should, when you're disclosing when you're not. And some of this is going to be adopting the right technology. Some of it's going to be awareness of what you've got. From an SUD provider perspective, you've got part 2 records, you've got this list of obligations, you've got to do those forms. But if you're further down in the ecosystem, do you know what Part 2 records you have and what obligations you have? What are your prohibition of redisclosures? Now, what are the new consents that are traveling with them going to say? So I think you've got to understand what you've got, and then you've got to be able to operationalize. The worst thing about getting consent for a TPO, as I always say, some people ask for consent for that. Why are you asking consent for something that you don't need when somebody's going to say no? How do you operationalize that when you don't typically do that? So, operationalizing things, educating your staff, understanding what you're going to do when you get those no's or when you get the revocations. And to David's point, even though they're saying you don't have to segregate data, you're going to need to know where this is, either to be able to comply with the subpoena for an administrative hearing that is going to require a separate consent, or to when somebody exercises their right to revoke consent, to stop disclosing records. So it's not an easy question, but I think it's the operational piece more than the forms.
Yeah, and just to tag one thing on there, Lisa, I think a really interesting one thing I think as Part 2 providers need to be thinking about is how are you going to have that conversation with patients? Because they are caught in kind of a bind. They have real consequences for sharing these data should they be breached somehow. For some benefits like TANF or SNAP benefits, they might have employment consequences, they might have child custody consequences, etc. On the other hand, as we see the Medicaid work requirements coming in line next year, patients should know that if they don't want to share these records for Part 2, their Part 2 records, then that might exclude them from an exemption from the work requirements. So an SUD is one type of exemption from the Medicaid work requirements. And so patients need to be thinking about sort of both sides, the pros and cons there. So I would just say, have a script ready and start thinking about how you're going to have some of those hard conversations with patients.
Yeah, so David, continuing sort of on that piece farther down the line, if you had to guess, what type of, enforcement do you think we're going to see next year as, folks are grappling with, some of these new requirements?
Yeah, I mean, one prediction is that eventually the government will reopen and that eventually we will see some sort of enforcement for Part 2 and HIPAA. It's important to note that again, it's not just the criminal penalties under DHA. Now we have SAMHSA may or may not exist, but the enforcement of Part 2 is being folded into OCR's responsibilities, and so that infrastructure that we have traditionally for enforcing HIPAA is now going to take in Part 2 as well. I mean, I think from my own experience working with folks inside government, and I know it probably feels different sometimes when you're on the receiving end, but I think regulators are going to have sympathy to the fact that these are new rules. I think they are going to be looking for good faith efforts at compliance. I think they're probably not going to have a lot of sympathy for providers or other entities that are not taking those good faith efforts, that are not trying. But I think they do recognize that there are still ambiguities. I know they're getting questions about these from me and other people. And so hoping that they are going to come out with some additional guidance to clarify some of the nuances. But the real key here is that some of these questions, like, are you a Part 2 provider? Is your consent form up to date? How are you going to make that consent form flow with the record? They've not been enforced before, and there are really significant penalties now. So we're going from 0 to 60 sort of in terms of the enforcement risk.
And I know we've talked about quite a few of the potential and actual challenges. Nichole, if you had to pick, what you think the biggest one is that as you and your team are trying to operationalize these, what would you say that is, or is that also an impossible question?
I tend to think that the hardest challenges are never the legal questions. They're the business and operational questions. And those get kicked back to attorneys a lot of the time, right? And they're like, "Oh, well, how do you do this?" And I'm like, "Well, that's not a legal question." And so to maybe be a little bit helpful, instead of just talking about the challenges, what our team does a lot and what I recommend, and I know I'm going to say this and folks listening are going to be like, when am I going to find the time to do that, Nichole? And you're right. But even if you can carve out a half an hour max to run a playbook, have your legal team, your operations team, a provider, if you can get a patient there, bonus points, or, somebody that all of us are patients. So if you can assign someone on your team to be a patient and take it through the steps, electronic healthcare is really just paper healthcare. We've just, done it a different way. So you can even do it with paper so you can kind of see it. But sit down on a table, have a tabletop exercise and say, okay, this is coming in. Let's pretend it's February. And, this is now coming in. Like, what are we doing? And take it through the steps. Pretend that a patient then revokes consent. Pretend that you have somebody subpoenaing it. Think through those types of things. If you can stick an additional half an hour on there, I would also recommend doing a tabletop exercise on a quote unquote breach, or how potentially the breach is being defined. We did that and it's weird. Trying to, I don't know how to describe it other than that. It sounds really easy. And I thought it was really easy. And I walked in very confident, like, oh, once again, like, this is just HIPAA. And when you try to take a set of definitions from one regulation and apply them in another regulation, I was like, I don't know what to do. And we deal with that a lot as attorneys, right? And then hopefully you do the right thing. And so that's, but they're business conversations about, like, what do we do? How do we document that? So it's really not fun when the first time you do that exercise is when you're like, do I have a 30-day or 60-day clock running? So to the extent that you can do that, record it, write down things, work with your attorneys on that. So that and have at least a little bit of a playbook when that hits, would highly recommend it. But get the teams together. You can make it fun, have lunch served, and really, try to say, okay, if we have to walk down and comply with this regulation, what does that look like? What are the decision points? And having everyone around the table, like, what are the pros and cons, puts and takes that we're willing to live with and not live with?
Yeah, I think that's such a great point, and probably goes for any sort of privacy compliance that you operating outside of the legal silo is so important to get teams on board. And also love that you found a way to end us off with some practical advice instead of just the negative of what's going to be hard about this. So with that, thank you so much, Lisa, Nichole, and David, for taking the time to participate in today's discussion on the Part 2 final rule. And thank you to all of our listeners. I'm your host, Laura DePonio. If you like what you've heard today, please don't forget to subscribe. Diagnosing Healthcare is available wherever you get your podcasts.
This podcast is presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of legal services to be performed is greater than the quality of legal services performed by other lawyers.